Welcome again to another installment of our interview with the experts here at Mayo Clinic, Rochester. My name's Malcolm Bell. I'm the Vice Chair of the Department of Cardiovascular Medicine, and I have pleasure in welcoming today my friend and colleague, Dr. Drew Rosenbaum. Drew works in our heart failure, mechanical circulatory support, and cardiac transplantation services, and is here today to talk to us about LVADs. Welcome, Drew.
Thanks for having me, Dr. Bell. Appreciate it.
Yeah, so really a fascinating and very new area in the last decade or so, and something which is really important. But before we really get into some of the discussion here, I just wonder if you could perhaps just define for our audience here, what type of VADs are we talking about? These are
Sure.
durable VADs, I assume, but also are we talking about destination therapy or a bridge to transplantation?
Right. So we're talking about durable left ventricular assist devices that are surgically implanted that provide blood flow from the left ventricle to the aorta. And because of recent trial data, their lines have been blurring between destination therapy and bridge to transplant, as there's been newer bridge to decision and bridge to recovery indications as well. So the lines are blurring in that field.
So, Drew, in the United States today, how many patients do you think might benefit from an LVAD?
Sure. Yeah. Well, the current estimates are about 6.5 million people over the age of 20 years old have heart failure. And that projection is estimated to grow to about 8 million by 2030. And of those patients, about 300,000 or so have NYHA class 3 or 4 symptoms are in the age range that would potentially benefit from LVAD therapy. Now, among those patients with advanced heart failure, probably 2/3 to 3/4 of those would have comorbidities that would preclude benefit from LVAD therapy. So probably in the range of 75,000 to 100,000 patients in the United States would be potentially eligible for LVAD therapy.
Put that into context, how many patients would be transplant candidates?
A roughly similar number, although there may be fewer sort of comorbidities that would prevent use of transplantation. And currently in the United States, approximately 4,000 to 5,000 patients are transplanted each year, and a similar number of LVADs are implanted.
Yeah, but that still leaves a huge number of patients who are left, unserved by either currently. So who are the patients that are going to really benefit from an LVAD placement?
Sure, and we can show the illustration, but the LVADs are indicated for HA stage D heart failure patients with either an ischemic or non-ischemic etiology and NYHA class 3B to 4 symptoms who are failing traditional medical therapy and have impaired exertional capacity or have developed cardiogenic shock. And one aspect I think that's overlooked with regard to LVAD therapy is that LVADs are beneficial by unloading the left ventricle and left atrium, but their true benefit is really improving low output symptoms. And patients with low cardiac output syndromes who tend not to get recurrent congestion actually probably derive the most benefit from LVADs, whereas patients with recurrent congestion due to a low compliance phenotype but intact cardiac output probably have the least benefit from LVAD therapy, broadly speaking.
Okay, so I hope our viewers can see the illustration there, but in that group of patients that you've described, or the groups of patients that you've described, are there age limits here in terms of are you too young to get an LVAD? And maybe as you answer that, you could perhaps just summarize how long these are durable for, and are there older age limits here? Are there specific cutoffs that would similar to what we have for transplantation?
Sure. So there's no absolute age limit on the lower end. Patients as young as preteens can receive an LVAD therapy. It's more of a size constraint thing, and obviously in a pediatric patient, the goal would be as a bridge to transplant. And we have performed LVAD implants in young patients for that purpose. On the older end, again, same idea. There's no absolute age limit. people with advanced heart failure tend to become quite frail when the age gets up into the 80s and 90s, though in appropriately selected patients, there could be octogenarians who would benefit from LVAD therapy. And we have implanted LVADs in folks over the age of 80, but it's a patient-specific decision.
Well, that gets to my next question then, because recognizing that not all septuagenarians or octogenarians are the same, but are there patients who clearly won't benefit from an LVAD? And obviously, we see some very, very ill patients with chronic severe congestive heart failure, and presumably not all of those are going to be eligible for an LVAD. So could you just maybe outline how you and your colleagues assess these patients in terms of who would be considered not to be a candidate?
Sure. Yeah. As I mentioned, 2/3 or 3/4 of patients probably wouldn't benefit from LVAD implantation due to comorbidities. And the most important ones are those of advanced end organ dysfunction. And those are the most significant contraindications often, which is specifically liver cirrhosis and end-stage renal disease. And outcomes are really quite poor with that. But even significant cerebrovascular disease, malignancy, severe psychiatric illness, very advanced age, which we discussed, or significant frailty don't tend to fare well. One of the things that we focus on is right heart function pre-implant, because LVAD therapy offers no support to the right ventricle, and in fact may be detrimental in some. And so invasive indices are often relied upon to assess the right ventricle before implant. And these include the pulmonary artery pulsatility index, or PAPI, or the right ventricular stroke work index. And these are markers pre-implant to determine adequacy of RV function. Some of the less common cardiac contraindications to LVAD therapy include a restrictive cardiomyopathy, who don't tend to benefit as much, and refractory ventricular arrhythmias, which aren't really solved by LVAD. Conversely, patients who are kind of NYHA class 3 without true signs or symptoms of progression to stage D heart failure really don't benefit because of the morbidity and mortality of LVAD implantation kind of outweighing its benefit.
Maybe I could just get your opinion here and advice for dealing with patients who do have end-stage renal disease. And I'm thinking particularly of patients who are on chronic hemodialysis, and
Right.
very, as we know, a very difficult population to take care of. But
Yeah.
we also see patients, who have maybe just recently gone on to dialysis, and then there's a question about if they went onto an LVAD, we could perhaps reverse that and get them off dialysis.
Right.
Do you see that in your practice, and how do you approach those patients?
Patients who have an acute presentation with cardiogenic shock, who require continuous hemodialysis or intermittent hemodialysis, very, in the acute time frame, may have renal function that recovers. And in those patients, we still consider them for LVAD and actually transplantation as well. But anyone who's sort of progressed through the chronic kidney disease stages sequentially generally do not have enough renal function to tolerate LVAD therapy or transplant without concomitant kidney transplant as well. And so end-stage renal disease, and the data suggests that people with end-stage renal disease do very poorly after LVAD. Yeah. The mortality is quite high, and so it really does present a almost absolute contraindication.
Okay, yeah, thanks for making that clear. I mean, the combination of advanced kidney disease and heart disease is really a bad one, isn't it? In so many respects. And then just in terms of current experience in patients who do get durable VAD, how long would these be expected to last?
Good question. Yeah, thanks. So the data are constantly evolving. The newest generation of LVADs are the HeartMate 3 LVADs. And we don't actually have natural history data because the first HeartMate 3s were implanted in 2015. But people are the 2-year survival between in the most recent trial with HeartMate 3 was actually similar to cardiac transplant. And so it's expected that the median survival could approach 7-8 years with these devices. And there's no serious mechanical reason why failure would occur at any point. And we have patients out, over a decade on durable mechanical circulatory support. So there's no, unlike the old pulsatile devices, there's no sort of inherent life limitation from the device standpoint alone.
Okay.
And obviously there's an opportunity for a device exchange too, if there's failure for any reason.
Sure. And then the remaining minute, Drew, here, if we just focus on the outpatient population, I'm not talking about the acute presentation, cardiogenic shock, and the CICU, but the outpatient population, what advice would you give to physicians who are taking care of patients with chronic or recent onset heart failure in terms of when they should be considered for referral to a center that would be able to offer assessment and implantation of an LVAD?
Sure, sure. Well, if you look at the illustration again, there was kind of a nice mnemonic recently described a few years ago for when to refer to an LVAD center, and that's folks who are recently initiated on chronic home inotrope therapy, patients, any patient with NYHA class 4 symptoms or a very high NT-proBNP, patients with end organ dysfunction in the setting of heart failure, a left ventricular ejection fraction less than 20%, or recent defibrillator shocks, patients with greater than one hospitalization in the last year for heart failure, patients on escalating diuretic therapy with low blood pressures less than 90 millimeters mercury, or patients in whom medical therapy needs to be withdrawn. These are kind of this makes up the mnemonic "I need help," and those are good things to think about with respect to referral to an LVAD center for consideration of implant.
Well, Drew, thank you very much. That's all we have time for today, but appreciate the fact that you could give us this really extraordinarily helpful insight into dealing with these critically ill patients and potentially providing them with life-saving therapy. So thank you so much for your time today.
Thanks, Dr. Bell.